going to be talking about a very interesting case of tardive dyskinesia in a patient with schizoaffective disorder initially suspected of neuroleptic-induced Parkinsonism. Neuroleptic-induced Parkinsonism, NIP, is a neurologic disorder that can result from the use of neuroleptic medications. The symptoms of NIP can mimic those of other neurologic disorders, included but not limited to multiple sclerosis. Tardive dyskinesia, TD, is an uncommon but potential complication of long-term use of antipsychotic medications also associated with movement disorders that can be often exacerbated by the abrupt withdrawal of neuroleptic medications. Here we present a case of a female patient with extensive history of schizoaffective disorder who presented to our hospital due to acute hypoxemic respiratory failure due to aspiration pneumonia with associated dysphagia to both solids and liquids. We're talking about a 55-year-old female. Again, she was admitted for acute hypoxemic respiratory failure in the setting of a new onset oropharyngeal dysphagia, and diffuse tremors were present on admission. Her past medical history includes long-standing schizoaffective disorder, chronic use of antipsychotic medications with a history of multiple failed therapies, and presumed neuroleptic-induced Parkinsonism. Failed therapies included olanzapine for 18 years, aripiprazole for 3 years, and fluphenazine for 1 year. Tremors were first noted while the patient was on fluphenazine, and they slightly improved with the addition of carbidopa-levodopa. However, this regimen was discontinued when the patient worsened with psychosis. She was then started on a combination of asenapine and carbazepine, which was stabilized her psychosis, and she was still taking these medications on admission. After resolution of her acute hypoxemic respiratory failure, the oropharyngeal dysphagia became the principal barrier to discharge. As part of the dysphagia workup, an MRI was ordered, revealing periventricular white matter, high T2 signaling intensity lesions consistent with demyelinating disease. This posed an alternative explanation for the patient's dysphagia, previously attributed to presumed NIP. However, no signs of active demyelination were present on imaging and CSF analysis. After discussion with multidisciplinary teams, we discontinued the neuroleptic medications with the expectations of ameliorating the medication's Parkinsonism side effect profile. However, within 24 hours, the patient had worsening symptoms, now displaying abnormal movements consistent with tardive dyskinesia, including persistent blinking or orofacial dyskinesia with persisting involuntary protrusion and retraction of the tongue. We rapidly restarted a different antipsychotic, cariprazine, as well as propranolol and bestropine. Carbidopa-levodopa was held at this time as well. Remarkable amelioration of tremor was evident in the patient within 24 hours of commencing treatment. A follow-up modified barium swallow study performed after 48 hours demonstrated resolution of aspiration and patient's tolerance to an IDDSI level 5 diet. This case provides importance of awareness to complications from chronic neuroleptic use that may result in tardive dyskinesia, along with the interplay between these medications and the dopaminergic agonist. Cariprazine was selected due to the lower incidence of tardive dyskinesia. A rough cessation of antipsychotics predisposes to tardive dyskinesia is more likely in patients with pre-existing neurologic disorders.